Greetings everyone, I am Dr. Ketan Barjatia, 5th year DRNB Neurosurgery resident at Bangalore, and today I'll be discussing about PCOM aneurysm. Posterior communicating artery aneurysm is one of the most common intracranial aneurysm we encounter in practice. It arises at the junction of internal carotid artery and the posterior communicating artery, typically at the origin of the vessel. Now, clinically, the most classical presentation is a painful third nerve palsy. The aneurysm compresses the oculomotor nerve, leading to ptosis, diplopia, and importantly, a dilated non-reactive pupil due to the parasympathetic fiber involvement. This is an important examination point. Pupil involving third nerve palsy is aneurysm unless proven otherwise. Of course, ruptures lead to subarachnoid hemorrhage, presenting with sudden severe headache, vomiting, and possible loss of consciousness. On imaging, CT scan detects hemorrhage, while the CT angiography or DSA confirms the aneurysm anatomy. From the surgical perspective, treatment options include microsurgical clipping or endovascular coiling. Clipping is typically done via a pterional approach with careful dissection of carotid cistern and identification of the aneurysm neck. One must preserve critical perforators, especially those supplying the thalamus and hypothalamus. In endovascular therapy, coiling is often preferred in selected cases, especially in elderly patients or those with high surgical risk. However, wide neck aneurysms may require adjuncts like stent-assisted coiling. A very important anatomical consideration is the presence of fetal type posterior cerebral artery, where the posterior circulation is largely dependent on the internal carotid via the PCOM. In such cases, preserving flow is absolutely essential. So, in summary, PCOM aneurysms is common, presenting classically with third nerve palsy and requires timely intervention, either clipping or coiling, based on patient and aneurysm characteristics.